recognition to Professor Hideyo Noguchi because, as many of you are probably aware, among the things that Professor Hideyo Noguchi was researching was yellow fever. And he actually died from yellow fever in Accra, Ghana. Today, Africa is facing the largest yellow fever epidemic in 30 years. And we are currently running in a shortage of vaccines for yellow fever, threatening a large population in Angola and in the Democratic Republic of Congo. So it's very timely that we have this workshop honoring Professor Hideyo Noguchi, and I'm sure that my panelists here, particularly Dr. Seth Berkley, will talk something about some of the challenges of providing vaccines during emergency conditions. So I wanted to bring this issue because it is very relevant to the legacy of Professor Hideyo Noguchi. I want to thank the people of Japan for both creating the Hideyo Noguchi Prize, but also for putting together TICAD even before the Sustainable Development Goals were announced, therefore driving us to the Sustainable Development Goals. I want to thank WHO and the government of Kenya in particular and other stakeholders who have put this seminar today in place, and to thank the young scientists, the future generation who are here, because you will take the legacies of all of us, including myself, forward in the years to come. And I also wish to recognize the fellow laureates of the Hideyo Noguchi Prize who are here, Professor Miriam Were and Professor Brian Greenwood. So we have a distinguished panel here to discuss medical services. We also have a group of young scientists who have discussed this very topic, who will give us a perspective from their view of medical services and some of the challenges that we are facing in Africa. And on my panel, to my extreme left, is Dr. Jackson Kioko, Director of Medical Services of Kenya, who will give us a voice from the field. What is happening in Kenya? What are we doing in terms of achieving universal health coverage? To my right is Dr. Seth Berkley, who is the CEO of Gavi, the largest and perhaps the most successful organization for driving life-saving vaccines across the world. And in my view, vaccines are the equivalent of putting someone on the moon. They are as strategic and as important as that. So we'll be delighted to hear from Dr. Seth Berkley. To my left is Mr. Brian Richmond, Director of Crown Agents, who will talk particularly about how do we respond during emergencies, during epidemics, and in particular the place of logistics and supply chain. Finally, to my right is Dr. Koya Ariyoshi from Nagasaki University, who is a son of Africa, who had part of his training here in Africa and understands Africa very well, and will give us a perspective on how Japan can contribute to the global health goals and how Japan can help us in Africa to achieve universal health coverage. So I'll kick off with Dr. Jackson Kioko. We would like to hear in 3 or 4 minutes a report from the field. How's Kenya doing? What's the scorecard? Is universal health coverage in Kenya as good as Kenya is at Olympics for being the top African country in terms of medals at the most recent Rio Olympics? Dr. Jackson.
Thank you very much, Alex, and I can assure you that Kenya is at the top of everything. We lead, others follow. First of all, mine is to welcome you to this beautiful city of Nairobi. It's the only city that is next to a national park. So welcome to the Nairobi National Park. Ladies and gentlemen, I'll just give you the Kenya Health Delivery System in the context of universal health coverage. Very briefly, just as a background that Kenya has a healthcare delivery system, which is a composite of public and private facilities. 45% of these healthcare delivery system facilities, actually the private, which are mainly in the urban setup. Of course, there are 6 levels of care, the community health services level 1, and the national referral hospitals are the 6th level of care. The care package is usually defined by what we call the Kenya Health Package for health. Of course, this country has experienced a double burden of diseases, communicable and the rising burden, what we see currently, of non-communicable diseases, including cancer and other non-communicable diseases like cardiovascular and injuries. We're seeing a lot of that. Of course, just like any other African country, Kenya was not lucky to attain the Millennium Development Goals. However, we have made significant progress in terms of improving or reducing the burden of HIV, malaria, and tuberculosis. Of course, with notable improvement in reproductive, maternal, child, and nutrition indicators. Of course, there are certain challenges that we note within our health systems. The challenges of access, equity, and coverages, and sustainability of health services still remain. But in our country, we are making deliberate efforts towards as we transition from MDG to SDG, towards building resilient and sustainable health systems that will ensure equal opportunities for essential health services to all Kenyans. Of course, we are more concerned in improving the health infrastructure, improving access, the quality of health care, training more health workers, and to ensure that there is more community participation in health services. Of course, we all know that universal health coverage is not a man by itself, but a means towards achieving universal SDGs. Of course, in a country, achieving universal health coverage and ending the epidemics of HIV, AIDS, and malaria and tuberculosis, and the rising trends of NCDs like the cancer, and responding to public health emergencies like the Ebola and yellow fever are some of the integral parts of a comprehensive approach in this country towards attaining the SDGs. Of course, as a country, we are putting strategic measures towards the implementation of universal health coverage to ensure that everyone, everywhere, is able to access quality health services without suffering from financial hardship. Of course, we have a constitution which is very much in place that assures that citizens have a right to quality and affordable health care. And our health policy, which spans from 2014 to 2013, which basically focuses on equity, access, patient-centeredness, efficiency, participation, multi-sectoral approach, and also the social accountability in delivery of healthcare services. Of course, this legal and policy framework, of course, demonstrates the Kenya's commitment towards implementation of universal health coverage. We have national programs and projects that have been put by this government of Kenya that will ensure the country is able to deliver health promises. There are health promises in the Constitution, health promises within the health policy. And some of these are the government has increased its domestic financing through increase in budgetary allocation. We have a program we call the Free Maternity Service that ensures pregnant women are able to access services from the time of antenatal to the postnatal care. And of course, we abolished the use of fee services in our primary health care services so that people who are in the rural areas are able to access services without any financial barriers. We have also a program of health subsidy insurance, which usually aims to protect, to cushion the elderly, the orphans, and the vulnerable population, especially people with severe disability. Another program is an output-based program, which is a future payment system that aims to support the women who are pregnant from the poor populations, especially in the rural areas. They're usually given a voucher that they use to access care in facilities. The recent one is managed equipment services that the government has introduced that will ensure that we have decentralized medical specialized services in all the 47 counties. 2 of the hospitals in each of the 47 counties are going to have specialized equipment in radiology, in theater, surgical theater, in renal, and also in critical care. Of course, the last one is upgrading of the slum health services. As we want to ensure that people who are in the informal settlement in our urban areas also have access to quality care, just like their counterparts in other areas. Of course, the last one, moderator, is a costed investment framework for reproductive, maternal, neonatal, adolescent, and child health, a program that under the global financing facility, that this country is going to further improve the reproductive, maternal, child health, and adolescent services in this country. And we believe these are some of the approaches that this country has put in place to ensure we move towards universal health coverage and further to implementing the SDGs. Thank you very much.
Thank you very much, Jackson. My apologies. Can the rapporteur for the Medical Services Group please join us to the front? Thank you very much, Jackson. And I think we shall wait to see whether Kenya gets a gold, silver, or bronze medal when we do the first audit to see how we are progressing in universal health coverage. Let's shift gear. Health is a global public good. And therefore, being a global public good, we cannot stand totally on our own as a country, as Kenya or Uganda. There are many global health initiatives that are there to support this global health good. The Global Fund, PEPFAR, but a prominent one is Gavi, that supports particularly the poorest of countries to access cutting-edge technology in terms of vaccines. And it's my pleasure that Seth Berkley, who's the CEO, will introduce what Gavi has done, what it's doing, but also futuristically, how Gavi can help us to achieve universal health coverage and the Sustainable Development Goals. Seth.
Thank you, Alex. And I want to start by congratulating the Japanese government for bringing TICAD to Africa, and it's very exciting. And you've already made the point that it's very appropriate. We're here talking about the legacy of Dr. Noguchi, given the large yellow fever outbreak that's going on. And just to say a word about that, here's a fascinating case. We've actually increased the price of yellow fever vaccines by 500% over the last 10 years. There are 4 manufacturers that are pre-qualified, so you'd expect that there would be enough vaccines. But one of the questions is this vaccine is still being made as it was in the original Rockefeller Foundation days. And we find ourselves with this fabulous vaccine, which is a single lifetime dose, provides protection, but not adequate quantities. And the secret to that really is we now have to do a much better job of working on the demand forecast, understanding and giving enough time for companies to move forward, and also to incentivize companies to invest in better technology and improvements in manufacturing, et cetera. So these are some of the challenges that we have, and maybe in the questions and answers we can talk about them. But to go on to your question about universal health coverage, I think, for me, I was part of the Lancet a Global Health Commission for Global Health by 2035. And, of course, we were very keen to see that there was universal health coverage. And there's a couple of important points. Health is critical towards development. And obviously, we need to have financial protection because people who get sick often get tipped into poverty. But one of the critical issues in thinking about universal health coverage is how does one implement that? And the Commission came up with the concept of progressive universalism. And the concept there is that countries should take the most cost-effective interventions, should try to get the widest scope for those as possible, and as they have more resources, add other interventions, and then more and more until they cover fully. Because the concern was that we don't end up with a veneer of very thin coverage or of funds being spent on things that are not cost-effective. So, this to me is a very important philosophy, particularly in Africa. And of course, the most cost-effective intervention is immunization. And immunization is special because if you look at this, it is the intervention that touches more lives than any other. So, if you look at Africa, 95+% of children on the continent have had at least one dose of vaccine.
Been important that has not just been an award ceremony, which is a wonderful occasion, and then forgotten for 5 years until the next event happens. But the organizers and the group looking after that have tried to keep the initiative going through having meetings like this. And so thank you to everybody as well who's organized this meeting, to the Kenyan people who've contributed, and also to our Japanese colleagues, and particularly to Dr. Weri. I'm going to talk to her afterwards. If I go out into town looking around, I'm going to ask for a little personal security from one of her speakers. So let's first introduce the speakers. That Dr. Iye couldn't come for this. I think, Bernard, are you representing him? Or you're here in your own right, because you're not on my program. Anyhow, that's fine. So Dr. Noguchi will talk to us. We have Professor Kwadwo, or Kojo to his friends, Koram, who is director of the Noguchi Institute, so it's very appropriate for in Accra for this occasion. Professor Suleiman Mboub, who's director of microbiology and virology at the Hospital Dantec in Dakar. So we have Francophone representative, and Dr. Kiru from Kenya. So I think Dr. Kiru was due to start, but just a few words from me before we get going. I mean, as Professor Kurokawa said at the beginning of the talk, I've been working actually for 50 years now, not 40 years, and a lot has changed in that time. And I'll just give you one example of how things have improved. In 1997, we had the first meeting of the malaria multilateral initiative for malaria meeting in Dakar in Senegal, and Dr. Varmus, who was then the director of NIH, came and stayed for a week in Africa for that meeting, and that was perhaps the renaissance of really research in Africa on malaria, which had been forgotten for perhaps 20 years. And I was involved in organizing that meeting. We had difficulty in finding 50 African researchers who were working on malaria to come to that meeting. Dakar has just won the competition to host the meeting. I think it will probably be in the beginning of 2018, end of 2017, but it'll be the 20th anniversary. I expect we will have 2,000 African researchers working on malaria at that meeting. So there has been progress, but we need more. And as I think anybody involved in global health realizes, the whole thing's got much more complicated than it was 20 years ago. It's not just distributing bed nets or ACTs or antiretrovirals. The whole thing has become much more heterogeneous, more complicated. We need different things happening in different parts of the country, and that needs really good scientists. And just because numbers are going down, I don't think that means that we should be reducing the amount of research that's being done. So the task of our speakers today is to talk about how we're going to empower malaria how we're going to empower research in Africa, and I hope we'll have time afterwards for a few discussions. So I think our first speaker is Dr. Kiru, who is from the KEMRI here, with its very strong links with Japan and all the support they've had, and you're going to tell us a little bit about links between KEMRI and Japan, I think, and research of your institute. So, Dr. Kiru.
So, good morning. I hope you still, no, good afternoon. I'm very, very happy to be here, representing KEMRI. And as the first speaker, Professor Were, actually introduced us, we actually introduced ourselves as a premier research institute in Africa. And this is not achieved just through our own initiative. but because we are supported by a lot of people. And actually, many of you may not know that Japan has really supported KEMRI right from the inception in 1979. And Japan has continued to be there. JICA has been a very key player in KEMRI, especially in the early 80s and 90s. And currently, we also have other Japanese arms, including the Nagasaki University. So when I was told to come to this meeting, I was told to talk about some of the challenges we face and how the collaborators actually come in to close some of those gaps. I can just summarize these challenges just in several words. First of all, it's funding. Every researcher talks about problem of funding. And in terms of funding, it's local and also global, simply because as a young researcher or a mid-level researcher, there's a lot of competition from established groups. But let me recognize the contribution of the government of Kenya. Recently, we were able to access quite a generous research kit, and this is available to KEMRI researchers. And we have actually been able to do a lot. This is the first year that we are working on this, and this is a very big advantage. Then, of course, we have a lot of collaborators, the Walter Reed Project, the CDC, the Wellcome Trust, and of course the Japanese institutions. In terms of infrastructure, we are still squeezed. Many of you know when KEMRI was introduced in 1979, we have of course outgrown that, the space that we have and also the structures. And in terms of this space, our labs are still not they're not exactly how we want them to be, but I think there's a lot of help that we are getting nowadays. And we believe that this will help, especially with our collaborators, even to help us achieve accreditation in all our major labs. I would recognize that the Japanese government, the JICA or New Team project, has helped us actually acquire a P3 lab, so we are able to process highly pathogenic bacteria that previously or pathogens that we could have actually sent abroad previously. The Japanese also support our production unit, and there we are able to make kits for HIV, hepatitis, and so on. And these kits are even now being sold in the region. The Wellcome Trust, the CDC, have helped us to make very, very good, what I would call ultra lab facilities in KEMRI. But there's one thing we have always wished for. When we do human medicine research, we normally rely on other hospitals. So this being a wish list, if the collaborators plus the government of Kenya at one time could help us possibly make our own referral and teaching hospital, that could really be important because it could actually link research to treatment. Human capacity, we still need the development of the minimum. So finally, is the issue of mentorship and access, expanding networks. We want to keep this growing because this will help us bridge the research gaps and also other gaps that we have. Thank you.
Thank you. Thank you.
One more time, say. Ewanuatio, nengima.